For the people on the Zoom, first and foremost, thanks for joining. But again, I don't have anywhere near the editorial experience, nor will I ever have the editorial experience Dr. Moore has. But I've reviewed my fair share of papers, and I've had some luck with publishing and some not so good luck with not publishing, as the case may be. But I see some kind of common themes that I thought might be helpful in giving guidance to everyone on the Zoom. For those who are prolific writers, this is going to be somewhat basic, so I apologize up front. For those who are a little bit newer to the game, I wish I knew some of this stuff back when I was writing my first couple of papers about some common errors that are made. When you want to sit down and write the paper, you've got, hopefully at this phase, you've already got your results, and you know the results. And so, those results tell a story. And that's kind of how I approach the paper. So when you start writing from the introduction or background, whatever the journal wants you to phrase it, the introduction should be no more than at most about 4 paragraphs, probably maybe even 3. It should start kind of as a wide funnel that kind of comes down, and you're kind of taking that reader down this journey. And that's kind of what I think of. So the first paragraph is really just, hey, here's kind of the basics of this issue. Rib fractures are the most common cause. Rib fractures are the most common form of chest trauma. Recent studies have shown mortality because of this. You're kind of just telling me at a 30,000-foot view why I should even bother reading this article, and just give me a little, here we go, perspective on where things stand. The second paragraph kind of starts bringing it down a little bit of like, okay, that's kind of the global problem. Here's kind of the problem I'm going to talk about. What we don't know about rib fractures is, pick something. Can we do them with empyema in the background? Some people say yes, some people say no. Pneumonia is common in rib fractures. Maybe we should, maybe we shouldn't. Third paragraph, we therefore set out to do the following. And now you kind of see how you kind of start with this global ribs break all the time. We don't know what to do when ribs are broken with people with pneumonia. Therefore, we did this study. And somewhere in that introduction, you have to state, my hypothesis is, or the objective of the study was. You can't just leave the reader wondering, okay, this is just like phenomenology. I just decided to kind of look at something. I had no clue what I was going to look at. And lo and behold, I found this thing. That doesn't work. So it's kind of starts as a funnel kind of coming down and ends with, my hypothesis was this, or the objectives of this study. Some studies don't lend themselves to hypotheses, but every study lends itself to an objective. And then if the study is really complicated, like for example, a big multi-center trial or a grant or what have you, you might even say the aims were. So the objective was this, and the aims were to discuss this and this. And that's it. The introduction just ended. So it's like 3 paragraphs in, as I said, at the most 4, and you're done. I'll stop there for a sec and turn back to Dr. Moore, who I think is on, are you up and running, Dr. Moore?
Can you see the screen now?
Yep.
Yeah, sorry for all this. Anyway, I can blow through this thing, and then I have the same basic message you do, but this is a lecture that Steve Shackelford and I used to give every year at the WST for authors and reviewers to enhance the quality of the material in the journal. And there's nothing unique to the Journal of Trauma, but a generic approach. So the first thing we did is that you can see in this first slide, these articles are all published. The first thing I did with my associate editors when I began my tenure back in 2012 is to meet as a group and figure out what we could do to help authors as well as reviewers, because we basically have the same game. We're playing the same roles. So these are the articles that are published in the Journal of Trauma that go through what I'm going to talk about. There's been a lot written about peer review, as you know. I found one of these processes interesting. This guy, Daniel Byrne, solicited input from all the editors in major journals to put together sort of why articles get rejected in peer review, and then he published a book. in sum, this was really the bottom line is that if you looked at why papers got rejected, and again, this is a full gamut, anything from science to a comic book, basically, and I've seen this fundamentally with the journal Trauma. The reason papers get rejected is that we don't articulate the problem well, and we wander through this morass of information, which really is uninterpretable what our message is. So fundamentally, I think it's important when you write a paper, even before you write it, but certainly as you prepare to write it, to take your topic and go into PubMed and figure out what's been published before. And this, I can't emphasize how important this is, and I know a lot of young authors think that PubMed is obsolete, and they certainly believe any article published before their birthday is not worth reading. But I can assure you that the reviewers don't hold the same concepts. So it's important to go figure out what's been published in these areas. And then list what you think the knowledge information exists, where the gap is, and what your hypothesis is. Just those three things. What are we trying to study here? And in one sentence, describe what you're trying to prove or reject. And then go meet with senior colleagues, if you have a mentor or whatever. And then I think before you even embark on the project, present this to a multidisciplinary meeting. Every week, we have a 3-hour lab meeting with clinical research and another 4-hour meeting with basic research. And we sit here, and this is how we start. People present their ideas. Do you think this is worth studying? So the most important thing is to define what the knowledge gap is you are studying. And this needs to be evident in the title, certainly well outlined in the introduction, and then reintroduced in the discussion of the paper. So start out with the title. The title, you know, people sometimes like to have catchy titles, but they shouldn't be misleading. I rather stick to a pretty simple statement. For example, multiple organ failure can be predicted as early as 12 hours after injury. Straightforward. Everybody knows what your knowledge gap is you're approaching. The abstract then, of course, is key because people invariably read the abstract before they read the paper, including, of course, the reviewers. And there's usually a pretty structure to that. Every journal is the same. The Journal of Trauma, you know, 300 words, but pretty much everyone is broken down to introduction, methods, results, and conclusions, and then ask for a level of evidence for clinical studies and 3 to 5 of keywords, and you shouldn't duplicate the title in that. So let's go through these things. Introduction. This is really what I think is key to get the reader's attention. So tell them what is known and what is not known, and so-called what's your gap and what's your hypothesis and objectives of your study. So let's take an example. And you know, humans think in terms of what they call chunking. That is 3 concepts at a time. No more, and less than that confuses you. So stick to 3 statements if you can. So here's one. So we start out with the aortic cross-clamping is a critical resuscitative intervention for life-threatening trauma. ED thoracotomy has been the standard forever. Ebola is new, less invasive. Okay, so those are 3 facts that are out there. You put that together, then what's the purpose of your study? Your hypothesis is Ebola can replace ED thoracotomy for non-thoracic life-threatening bleeding. So you tell them what's out there, you tell them there's a new device, and you say, okay, what I'm going to tell you now is I'm going to try to determine whether this new approach should replace a previous approach. Then the methods are pretty straightforward, and I think we spend far too much time in methods, but they should be systematic and use supplemental detail if you have a complex methodology. but important to include reasonably comprehensive biostatistics. If you get into some of the new complex statistics, sit down with your biostatistician and have them write them for you. Because if you start out with a poor description of biostatistics, then the reviewer is going to be skeptical of your results. Then the results you present in a logical order and use figures for key data. But the important thing is in the results, don't start wandering off into discussing your results. Just present the facts. Now, cartoons are good. If you're presenting a complex topic, then these type of cartoons can be very good. If you're going to talk about trauma-induced coagulopathy and what the role of PI1 is in that phenotype, then you put this in front and say, trauma-induced coagulopathy is complicated. There are various things that drive it, and there's various mediators. We're going to focus on PI1 levels, and that influences fibrinolysis. So for those who aren't familiar with all the verities of the topic, this brings you into focus, and you can identify exactly what you're going to focus on your paper. Now, another trick, which I hate to give all my tricks away, of course, it doesn't matter because I'm about ready to go to heaven anyway. But if you want to get citations on your paper, one of the best ways to do that is to describe your unique message in a figure. This is a paper we just published in Transfusion on the role of hypocalcemia in trauma-induced coagulopathy. And we are describing what we referred to a couple years ago as a death time. And as you know, we coined the lethal triad, and now we're going to death time. And we show here pictorially what is the death timing. So these kind of figures, others then will copy when they want to make slides and talk about the topic. And sure enough, you'll get cited because they'll use your figure in their talks. Now, it's important to remember that virtually all journals now, and certainly the Journal of Trauma, requires the Equator Network description of your studies. So, for example, for randomized trials, you're obligated to put in a consort diagram showing, how many patients are enrolled, how many are dropped out, and what the randomization groups are. And for all the studies, observational, strobe, systematic reviews, PRISM, and so on, there's these standard ways to frame how you want to present them. Now, if they're complicated, often you put that in a supplemental, but if not complicated, you ought to put it directly into your paper. Now, the discussion is probably the hardest thing to write and probably the most confusing to read. But we, at least as our group, Journal of Trauma, thought the way the discussion ought to be written is, let's open up with the first sentence, reiterate what your hypothesis is. My hypothesis, Reboa can replace ED thoracotomy for non-thoracic life-threatening hemorrhage. And then say, hey, what we found in this study was 1, 2, 3. So you sort of summarize what the key findings of your article. And again, I encourage you to try to sort of pigeonhole these into 3 topics because that's the way humans' brains work. And then go, okay, here's the 3 findings, and here's how they have helped us bridge this knowledge gap that we have attempted to approach. And then you don't want to, of course, kill your paper. You may know some things about limitations you don't want others to know, but be reasonably comprehensive about what the issues are. Now, frankly, if you think of a study limitation, it's likely a reviewer is going to listen to it anyway. So you might as well confess your sins now and not have your paper rejected because someone says, oh, this is worthless because they haven't done this, haven't done that, and haven't done this. But don't, again, get too detailed and sell you down the river because if you've satisfied your hypothesis, your contribution is worthy. And then in your concluding paragraph, and it depends how complex the topic is, just tell them, okay, here's what I showed you. And summarize that so they end up the paper recognizing what you're trying to impart with your paper. Now, some warnings about papers. You got to be careful about duplication of material. this is an outline of the ones that the World Association of Medical Editors put out a couple of years ago to quantify what kind of level they are. The most common really is salamicizing, in which you publish a paper that really is part of a bigger paper. And in my estimation, reviewers, by and large, don't like to see that, and certainly don't write a promissory note in the concluding limitations that we're going to now do, or we have looked at and we will publish later. Furthermore, I'd argue that, of course, I've made all these mistakes in my life. I'd argue that the papers you present that are broken into components don't have the same impact if you don't put them all down at the same single publication. I could give you plenty of examples, and I better not because you'll probably recognize some of the authors. But the point is, don't try with a salami slicing. Don't try to get 3 papers out of one project. Write it up, do it well, and it'll be appreciated and cited very highly if you're comprehensive in that topic. So in sum, really, it's pretty simple. Success in peer review is figure out a current relative issue. Again, find this gap. State a clear hypothesis, nothing better than a pure, simple hypothesis. Use optimal methods, which you're all familiar with. And then in that discussion, convince them with a translatable message that they need to read the paper. So that's pretty much it. It's pretty straightforward, but those are the lessons anyway I've learned in my time in being both an author and a reviewer.
Outstanding. You guys have any questions? You want to kind of open up? If not, we can kind of keep talking a little bit longer.
And by the way, Sarani, I don't have any concern about putting these slides on your website for your group. They're mine, and there's no copyright issues. But if you want to put them on, you feel free to share them.
That would be great. Thank you. If you wouldn't mind sending it over to me, that would be fantastic.
So if there's no other questions, I'll kind of just go down the road a little bit and maybe we can have a conversation. We talked about the introduction section. I think Dr. Moore kind of reiterated as we were talking the funnel approach to intro. When you get on to methods, I have actually a question for maybe Dr. Moore or anybody else. What I see a lot of times these days is the following opening sentence. A retrospective study was performed using prospectively collected data. And I'm like, well, all data are prospectively collected unless you just made them up. So to me, that sentence doesn't make any sense. And I always wonder, as a reviewer, are you trying to pull the wool over my eyes and call a retrospective study a prospective study? So any thoughts on that vernacular, Dr. Moore? A retrospective study was done using prospectively collected data.
Well, I think it's unnecessarily complicated. I take a little different read on it, frankly, and I use different verbiage. But as you know, we have huge databases at our institution that we collect very meticulously and prospectively with specific objectives for the study in mind. So we have a multiple organ failure, and we define from the very beginning. We want to define risk factors, outcome, and so on. Now we have trauma-induced coagulopathy. We want to define mechanisms, unique phenotypes, and management. So in essence, we just didn't retrospectively think about, well, is there fibrinolysis shut down in our study? Well, that was part of our plan. So I don't think you have to get into the weeds about retrospective of prospective. I would just simply say we established a database in 1976 on multiple organ failure, and we now have 700,212 patients, and we queried that database for this question. And then you don't have to get into that verbiage game we play. I understand what you're saying. A lot of people get into the minutiae about retrospective of prospective, but I think it's a little different if you set up a database with that specifically in mind. That being said, a lot of databases, as you know, like TQIP, National Trauma Data, aren't set up. So when someone says we looked at the TQIP retrospectively to look at what the risk factors for hyperfibrinolysis are, A, you can't find them because the granularity is not pure, and B, that was never designed for that. So it is, in fact, a retrospective review of a prospective database.
Yeah, I agree with that. So, I mean, really, as you guys are trying to now describe your study type, which gets to levels of evidence and all, everybody always wants to upcode their study, obviously, right? I think what Dr. Moore said is right on the spot. If the data collection tool was designed after you already had a hypothesis, I want to compare the views of Sarah Ann Whitback to Tom White. With this particular hypothesis, Sarah Ann's views are more accurate than Tom White's when it comes to how to set up a meeting. I therefore created a questionnaire and I spread that across CWIS and I collected the data. That is a prospective study. But if you ask the question after the data were already collected, i.e., I'm going to go to the trauma registry and I want to ask the trauma registry, give me all the car crashes, and I want to know what the risk factors are for a car crash. That is a retrospective data. So it's the time point is, when was the data collection tool created, before or after the hypothesis? If the data collection tool is after the hypothesis, then you have a prospective data. If it's before the hypothesis, it is a retrospective study. It's kind of that simple. And obviously randomized is randomized. That should be the opening study. You know, after obtaining IRB approval, a blankety type study was done from this particular time period, because we have to know the inclusion time, right? If you go all the way back, as Dr. Moore said, to 1970, whatever, well, the first question I have in my mind as the reader or as the reviewer is, whatever results you've achieved, are they still relevant today? I mean, surely what happened in 1970 is no longer applicable to 2022. So I need to know the time frame of the study. And then get into the design, right? Here's what we query. Patient demographics, comorbid conditions, whatever the issue may have been that you queried. You're kind of describing the methods to me. And then usually, classically, the last paragraph of the method section, the very last paragraph, are the statistical analyses, which is kind of what Dr. Moore mentioned. You got to tell me how you set about describing the statistics. Now, if you are the author, one of the times I'm going to completely get you real fast is if you throw down a bunch of parametric studies for a small study. Oh, we studied this and that using a student t-test. And I'm thinking to myself, you only have 50 patients total. Are the data distributed normally? And if they're not, and odds are they're not, then the student t-test is the wrong test. Why didn't you use a non-parametric study like a Mann-Whitney U or something to that effect? Okay? Or if the data are large, if you have hundreds and hundreds of data points, we have 700 patients enrolled in this trial, we have 500 patients enrolled in this trial, then the normality distribution doesn't matter because it will skew itself. So the smaller your data set, the more kind of anal you have to be to make sure that the proper statistical test was done. A non-parametric will always give you benefit of the doubt because you load the chips against yourself. A reviewer will never say, why did you do a Mann-Whitney? You should have done a t-test. But the opposite they'll tell you all the time. This is where I think having a statistician or someone who is a little bit statistically savvy, which I am not, I've pretty much maxed out my knowledge right now, it's very helpful in addressing these types of things. If you did a multivariate regression, you got to tell me what was in the regression model. Things like that in the results section. In the method section. The results section usually starts with this many patients were enrolled. A lot of times what I find is people accidentally put the number of enrolled patients in the methods. That's not a method. That's a result. Here's what happened when I did the study. This many people were put into the study. So it usually starts with this many patients were enrolled, so I know how many cohort we're talking about. Helps the reader understand. If it's a study of 10 patients, I may just stop reading it. It's not generalizable. Don't know what to do with that information. But if it's a big study, I may continue reading it. And then the next sentence after the how many patients were enrolled should be, tell me about those people. Are they relevant to my patient population? I enrolled 500 people. They were all 20-year-old college males. Well, that doesn't help me if I'm in a geriatric heavy trauma center. So the demographics matter, the comorbid conditions, whatever it is you gathered, and explain that. And usually that becomes table 1. So table 1, generally speaking, becomes your demographic table. If you're using a consort type diagram as far as who was and was not enrolled, that will also be like figure 1 to kind of tell the reader, okay, here's what we're talking about. Here are the people that we excluded. Maybe that created some bias, maybe it didn't, but here's the deal. Here are the people that we included. Here's what they look like. Are they relevant to your patient population? You take that information, reader, and apply it. And then the rest of it is exactly what Dr. Moore said. Just the facts, man. Just tell me the facts. No editorializing. Here's what happened to this group. Here's what happened to that group. And if you're doing it right, your results section may be as short as 3 paragraphs. It may be very, very simple if the hypothesis was simple. Short result does not mean poor study. Short result means nice, crisp, succinct study. It's like presenting on surgical rounds. I don't need you to tell me a chapter when half a page will do. And then the body of your results, like the meat of your paper, what you were really going after, should kind of be in the middle toward the end of the results section, because the top part of the results section is more a demographic descriptor of who was included. So I, the reader, have to kind of get past that. I have to know who was in the study, what they were like, and then once I get to like the second or maybe third paragraph is when I'm really understanding, okay, here's what he found or she found on univariate analysis and on multivariate analysis, okay? And then remember, the multivariate is, at the end of the day, what really matters. People blow right past the multivariate. You know, they're going to be like, oh, on univariate, we found this, 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 this. Of course, on multivariate, all of that statistical significance disappeared. I'm not going to let that stop in the way of making a conclusion that is polar opposite what I just told you, right? And I'm going to find you on that. I'm going to say, well, wait a second. On univariate analysis, you found that men are more likely to commit medical errors than women. But once you controlled for age and for experience, that went away. So your conclusion cannot be, thus, men are more likely to commit. No, you discounted it. You disproved it on a multivariate, and a multivariate trumps a univariate, okay? So that's kind of the results section. And then the discussion is, you know, in my opinion, the least useful portion of the paper, because it's just you talking. At this point, you just kind of become like somewhere between Fox News and CNN. God only knows where the truth is. It surely is not in your discussion, right? It's whatever you feel like saying. So you kind of start again with a summation of your paper. We set out to do this, and here's what we found. That's paragraph 1. Paragraph 1 is nothing more than a summation of the paper. That's all it is. And then paragraphs 2 through maybe 4, 5 are going to be a discussion. That's like Dr. Moore said. This is where you need to have your PubMed handy so you can go back and say, look, Sarani and White found the following. Our study is or is not congruent with their findings. If it is congruent with the findings, you better very quickly tell me how you are adding to the findings. Otherwise, all you did was prove whatever Sarani and White already knew to be true anyway. So how does your paper help anybody? Maybe you did it in a larger data set, thereby making it more generalizable. Maybe you looked at it slightly differently. But it's helpful to say, Sarani and White found this, and we built on that. Okay, kind of remember the concept of science, that we build on each other's shoulders. Or your study found something entirely opposite. Sarani and White said turn left, but you know what? We found turning right is substantially better. Well, then you got to talk about that. Why? Well, maybe Sarani and White had some methodological shortcomings in their paper that we resolved. Maybe their patient cohort was different than our patient cohort. So if you're a 20-year-old college male, turn left. But if my patient cohort was a 65-year-old and older patient, turn right. So you're kind of understanding now how to link your trial into the context of others and make it kind of a story out of the whole thing. And then last and certainly not least, as Dr. Moore said, is the limitations section. You got to be honest with the limitations, or I'll be honest for you, right? And if you're honest and I'm reading the paper, I'm going to give you a lot of benefit of the doubt. Because let's face it, I've also written some papers that have not exactly ended in the New England Journal of Medicine. So I've kind of done what you've done. And if you're honest about it, this was a single center retrospective study. This was a questionnaire. You know, this does not have a control arm. We use historical controls. Whatever the issues may be, you gotta put them into the limitations. Now, you can explain some of that away. You can say, well, look, we did this study. One of the limitations of this study is it's only 50 patients, okay? But we found statistical significance. Okay, that matters. We acknowledge the results may not be generalizable because the sample size is small, but significant is significant. And thus, we think this study should be redone in a larger cohort. That's a great way to go. Okay? So the limitation doesn't mean that it's a death knell. What it says is, here's the next step, reader, if you want to go and take this study one step further. And then last and certainly not least, well, I guess two more things and I'll stop. When you're writing your discussion section, hopefully you already thought about this in the study design phase, like in the 3-hour Gene Moore Thinkathon before you started the project going. But in the discussion section, you must answer the question, so what? That question must be answered. So what? Right? Otherwise, you end up with like Drosophila have, one more chromosome than non-Drosophila. And you're like, well, who cares? So the so what factor has to be answered. I did a study once. I tried to do a study once and we killed it. Many years ago, I was trying to get my hands on all of the shootings in Washington, D.C. and ask the question, what's the characteristics of the assailants? And we had a very hard time answering the so what question, because who do you think are the characteristics of a firearm related injury in an inner city? Everyone already knows. It's going to be young African-American male, right? And we didn't go one step further to say, well, wait a second. What prones these kids to shooting? Is it a socioeconomic thing? Is it an education thing? Is it an unemployment thing? Is it an income thing? Why does this happen? All we had was, gee, people in Washington, D.C. who discharge firearms tend to be young African-American males. There was no so what factor. Paper denied. Really poorly designed project from the get-go, if you think about it. So think about that. And then last, in the conclusion needs to be about 3 sentences, and that's all it is. Okay? Probably the single biggest error people make in the conclusion is they go well beyond the results and they start just opining on things that are not fact-based. Every sentence, every word in the conclusion must be supported by a fact in the results themselves. You cannot go off target. You can go off target a little bit in the discussion. That's where you kind of opine about Fox News versus CNN. But the conclusion has to go right back to the results and just tell me, here's what happened. And a lot of times in the conclusion, people will end with, future studies are needed, and that's fine too. So that's kind of my overview to add a little verbiage around the slides and experience that Dr. Moore gave you guys. I have not been monitoring the chat because I've been too busy chatting myself. So I'll stop there for a sec and I'll start reading some of these chat questions and see if anybody else has any other questions for Dr. Moore or myself. All right, so Sebastian posted a link from Melina Kibe, who is the editor-in-chief of JAMA Surgery and now dean of UVA, on how to write a paper. That would be a good resource for you guys to grab, I think. Can you comment on manuscripts that don't fit this archetype, studies that aren't really studies, observational, editorial, cautionary? Dr. Moore, you want to talk about that? Maybe like brief reports versus editorials versus, things that are not exactly in the original manuscript type?
Well, I think those have to be targeted for journals that have, the variants that they entertain. So not every journal now or ever has, accepted case reports or challenging cases or how I do it and so on. But if you look through a variety of journals, generally you'll find one that'll allow an atypical report.
One question, Doctor, I'll get to you in 2 seconds, Dr. Su, but this is kind of a follow-up for Dr. Moore. It says, how would you label a study that collects data prospectively but uses a historical control? So there's no control arm. Would that still be a prospective trial?
No, that would be just as described. It would be a trial compared to historic controls, but it's necessarily not randomized, as you know. And if it's the first time someone's done it, it has tremendous value. The problem sometimes, again, this is why it's important to go to PubMed. People end up reporting, this historic control in their prospective, and then someone's done a prospective randomized trial 2 years ago. I can't tell you how many times in the Journal of Trauma I read an article and I go, wait a second, I think I read that somewhere and looked it up. Sure, it's done 4 years ago and it's randomized. So your prospective compared to a cohort is not going to get into a journal that has already published that type of work. Again, not that it's not meritorious if it's the first time or unique, but in general, you got to be straightforward. This is what you're comparing.
Dr. Sue, you have your hand up.
Yeah, look, that's thanks very much. That was excellent. Just to clarify on the point that Dr. Moore just made, what is your suggestion for those particular studies that involve a clinical practice change in the hospital where you are, and you're examining the outcomes from after the change to before the change? Because I've seen lots of descriptions about pre-post. It's not technically a cohort. It's not technically a case control. Doesn't actually quite fit in with the strict definitions of study methodology.
There is a study done by Fred Pieracci, and I'm going to try to look it up really, really quickly. So when Dr. Pieracci came to Denver Health, and please correct me if I'm wrong, Dr. Moore, but this is kind of how he tells the story. He says when he came to Denver Health, he found that rib plating was not terribly in vogue, and he really wanted to do the rib plating. And then he and Dr. Moore kind of made a deal where they would start doing some rib plating, and if rib plating was good, then maybe Dr. Moore would allow it to continue and not kill Fred. And if rib plating was bad, then Dr. Moore would fire Fred, which I think most of us would too as well. I'm being a little facetious on purpose. I'm trying to be a little bit funny. But Pieracci ended up publishing that paper. It's a paper that I quote all the time in my slide deck for rib plating. He's the first author, and he labeled it Prospective Controlled Clinical Evaluation of Surgical Stabilization of Rib Fractures. And it's kind of what you're alluding to, Dr. Sue, in that it's a study that looks at a historical control based on a change in clinical practice moving forward. And so that's kind of what I would call that as well. I would not necessarily say, I think a prospective case control is pretty much what it is. That's how I would label it. We're looking to do something similar here in DC. We've worked with our fire department to soon to implement a change. We want the paramedics to give drug X, but because we can't randomize, we're going to have to use historical control to see what happened to patients when they got X versus when they didn't get X, and the second group is going to be the historical control. So we're going to call it exactly that. We're going to call it a prospective case control trial, and see how it goes. I don't know if Dr. Moore has any other insights like how to better categorize that type of study.
I'd just be as descriptive as you can and straightforward with it.
Yeah.
Yeah, that's great. The other question that I had really was often the introduction, background, and the discussion have the similar kind of points in terms of describing what is known to set up, like your question, and then your comparison in the discussion about how your study findings compared, they often overlap. So what suggestions do you guys have in terms of, mitigating that because you don't really want to duplicate it? And I see that a lot. Like I see it, it's sort of restated in both sections.
Well, again, I think the purpose of the introduction is to define your knowledge gap. So you come up with your 3 points. This is shown, this is new, I'm going to show this. I'm going to determine if this is better. Then once you get your discussion, you definitely should not reiterate your introduction, which a lot of manuscripts unfortunately do, as you know. It's usually pretty well tolerated, but some journals are pretty fastidious about number of words and so on. But I think, again, in your discussion, you just reiterate your hypothesis. The knowledge gap was, our hypothesis was, and then you tell them what your findings are. Now, you can then compare studies that you alluded to in your introduction to say, unlike so-and-so study in 2013, R showed this, and we believe the reason is this. But you shouldn't just reiterate in 2013 someone showed this, in 2017 this. You should compare your results with the previous studies. And so in that way, you don't really duplicate the introduction unless there's a reason to, if that makes sense.
Yeah, one way I try to double check my math to make sure I'm doing what Dr. Moore just said is I look at the number of references that I place in the introduction. There absolutely needs to be references in the intro to back up your whole introduction, what the problem is, what the knowledge gap is. So you'll need, let's say if I have 15 references in one paper, probably about 4 or 5 will be in the intro, but the majority need to be in the discussion, because it's really in the discussion that I'm comparing my findings to those before me. If the opposite is true, if you're finding more references in the intro than in the discussion, then you've kind of done it backwards. And it's kind of what you just alluded to, Dr. Sue. You're kind of reiterating everything again at the back end of the paper. So I kind of look at the balance of the paper as a whole. Some references in the intro, maybe one reference in the methods, really no references at all in the results, and then a lot of references in the discussion.
If I may, about the question about archetypes and somewhat atypical papers, if you have a podium at CWIS, please write a manuscript and submit it. In 2020, the Society did a Delphi, and the Journal of Trauma hadn't published a Delphi in a long time, and it was actually initially reviewed somewhat poorly within CWIS, and then Dr. Moore actually really liked it and took it up and ended up putting it in the journal. Similarly, last year, Dr. Coco did a really fascinating presentation at the 2021 meeting about converting the gold standard prospective randomized controlled trial into a target trial approach. And she didn't actually, she didn't do research per se. She studied 4 papers that had been written, one of which was actually from Dr. Moore, and looked at them and analyzed them and said how a target trial approach might be more beneficial to answering this question, or what some of the elements of that were. I remember she actually called me and said, I don't know if I should submit this because I don't think this was publishable because there's not really a p-value in this paper. And I said, submit it, because sometimes the most interesting papers in an edition of whatever your favorite journal is aren't necessarily these archetypes. And Dr. Moore loved it and took it up and published it. And it's in the December 21 issue, the CWIS edition, the last CWIS edition that came out. So I just want to just put a plug in for, just because research is somewhat atypical does not by any means mean that it is unpublishable.
Yeah, I think in that regard, I see the clock is ticking down over here, Sebastian. So a couple of the little stylistic points that just makes the paper easy to read, makes the reviewer happy, makes the editor happy, hopefully makes the reader, him or herself, happy, is in the results section, write the results, actually write out the results. What's a little bit annoying is to say, look, we found that, this is better than that, P equals 0.03. But you don't actually write the results. For the result, I now need to stop reading, go to table 3, look up table 3, see what the actual numbers are, come back to the text, find out where I was, continue reading until I get to the next p-value, and then history repeats itself. Very staccato, very non-smooth way of reading a paper. Just put the results right there, 12 plus or minus 5 versus 7 plus or minus 2, P equals 0.03. Okay, we're good to go. If you don't want to use p-values, if you're using some other methodology that requires odds ratios, put the confidence interval. Make sure you're internally consistent. If you're using a non-parametric distribution, if you're using a Mann-Whitney U, for example, okay, something like that, you cannot report out averages and standard deviations. You have to report medians and interquartile range, because an average and a standard deviation assumes a normal distribution of the data. So if you're going to go with non-parametric, you got to stick with non-parametric. You can't flip horses midfield. So those kind of things will help you get past the easy stuff of the reviewers. Tables and graphs are exceedingly helpful, so long as it, one, don't overlap. Don't show me a table and then a graph of the same thing. That's just unnecessary. Pick a table or a graph, whatever you think depicts the information better. But then every table or every graph must be freestanding. I was just reading a paper today, and there was a table. The table didn't have a title. There's no title on the table. And so to now know what that table is supposed to mean, I have to go find it in the results and then say, okay, what's this even supposed to indicate? And then come back and look at the table. So every table and every figure must be freestanding. If you just give me that table or figure and nothing else, I should at the very least be able to tell you what information is contained in that. So abbreviations must be defined in a legend, and it must have a title, and make sure that the p-values and all the other parameters that you want are clearly delineated there. So just look at it and say, is this freestanding? Yes or no. If it is not freestanding, if the abbreviations are not defined, if there's no title, if it's missing values, it's not adequate. You gotta buff it up a little bit. Any other comments from anybody?
The other comment I'd have, which is a constant struggle I have in our group, is that when you write a paper, all the co-authors should participate to justify their authorship, but you can't send the paper till 11 o'clock the night before it's due for a revision. And everybody does it differently. I start out sending out an email and say, okay, we got a topic. Let me know if you're interested. And then if they do write back, then I go, I do it piecemeal. I say, okay, I'm going to write the introduction here. I'm going to send you 10 references that I think are important for you to read to understand why we're doing this. Send it out to everybody. Then write your methods and results are pretty straightforward. Send it out again, and then do the discussion last. But those kind of processes ought to occur over 3 or 4 weeks, not again 2 or 3 days before the manuscript is back for a revision. I am disappointed how everybody thinks they need a little badge in a wall, that everybody thinks they should be co-authors just because they talked about the topic at an M&M or one of their patients was in the paper. They had to work for it, and they should learn that. And you should insist. That's why I send that original one out. And if they don't respond and don't participate, they're not authors. And when they complain it comes out 8 months later, I say, well, you were given your choice. Next time, pay attention.
Okay. Any other comments? I think we're down to our last 5 or so minutes. Do you want to remind everyone of the submission process, Sebastian, for CWIS and then vis-a-vis JTAX?
Absolutely, happy to do it. So as you all probably are well aware, but just to reiterate, everything that is a podium at the Just Wonders Society Summit, of which there are 37, kudos to the Society for being so incredibly productive in the midst of COVID, goes directly to the Journal of Trauma, not to the Society, and is submitted as any other paper would be to JTAX. You will select CWIS 2022 as the paper type, and you will follow the instructions for authors of an original submission. There are no case series that will be accepted or case studies, that sort of thing. We've heard from all 37 podium presenters that they plan to submit something. As Sarah Ann already said, the deadline is April 1st to give our reviewers adequate time for a first pass of review prior to our summit. We've done that every year. It's a horrendous amount of work, but I think it is of huge benefit because it means that there is someone sitting in the audience, probably two someone sitting in the audience that have reviewed your manuscript when you're up there presenting at the podium. And I think that only benefits the quality of our meeting. So I just want to thank Dr. Sarani and Dr. Moore and everyone else on this call for joining. It's really incredible to have two such prolific authors and editors give us their take and their advice. I am very optimistic about this process. I think the Journal of Trauma has been an amazing partner to us, and I really look forward to doing the editorial work to getting another fantastic December issue together. If anybody has any needs or questions, you can always reach out to me or anyone else within the society. Anything
Just
else?
a quick reminder, if you have not booked your hotel room, the hotel block expires in 11 days. So the time is 9. Go ahead and get on that. And also, I've seen a batch of registrations where people accidentally registered as an online attendee, but then realized they meant to register as an on-site attendee. So just be cautious when you're registering about what you intend to register for. That would be super helpful versus going through the refund and re-register process. That would be great. Otherwise, we just look forward to reading your terrific papers. And as Dr. Schubel said, if you have any problems or questions, please reach out anytime.
All right, guys. Well, thank you for your time.
Yay.
Okay.
Thanks.
Bye, Dr. Moore.
Thanks. Bye.
Thank you.
Bye.
Bye, guys.